Yeah, thanks very much, Jeremy. It is a pleasure to be talking to you once again. Normally in the Right to Care offices in the little room, it's quite nice actually doing it with the larger audience that can actually attend as well. So this really is an incredibly important point, and it always shocks me the cavalier attitude that people have towards central venous catheters. And in fact, it is one of the most important sources or sites of sepsis in the hospital today. We know that as far as stewardship is concerned, there really are two pillars. There's your infection prevention and control and antibiotic stewardship. That means using the antibiotics in an appropriate manner as well. And obviously this talk falls into the realm of the IPC in particular. Hospital-acquired sepsis is particularly a problem in South Africa and in developing countries. Hospital-acquired infection in these developing countries are up to 3 times that of the United States. One wonders often whether, in fact, they record them because they actually are marked or graded according to how many hospital-acquired infections they actually do have as well. If you have a look at the incidence and you look at the expense of hospital-acquired infections, the incidence in the black and the expense in the gray, surgical site infections are right up there in terms of both. CLABSI, the incidence is lower than surgical site infection, but it costs a lot of money to actually have them. And you can see the other figures for VAP and catheter-associated UTIs, and of course C. diff as well. We've got a number of IV devices, and although I'm talking about central line associated bloodstream infections, do remember that perhaps the catheters that have the worst care overall are the peripheral intravenous devices. And as you can see, in fact, when you're looking at the bloodstream infection from these devices, they're about 0.6 per 1,000 catheter days. And that's as opposed to arterial lines, which are actually quite high, surprisingly so, and the central venous catheters, which are 2.3 bloodstream infections per catheter days. And you might say, well, therefore, that's a very low number in terms of peripheral lines. But if you're talking about the total number of peripheral catheters, of course, that translates into a significant number. And this is a selection of the dreadful ones one sees when one's walking around the wards in terms of lines which have been inadequately placed, they've bled underneath them, the actual dressing is lifting on all around them as well. Many of them hang in the breeze, as for example, this bottom one over here that hangs in the breeze and there without any covering whatsoever. And in fact, that is also frequently associated with infection and also bloodstream infection. But we really are talking about the central catheters. There are also, in fact, the PICCs, the peripherally inserted central catheters as well, which were initially, when they were brought out, they underwent a significant popularity because it was presumed that there would be less infection. But in fact, they actually do have probably the same number of complications, both related to severe peripheral edema in the arms, but also in terms of infection as well. And because of the fact that it's felt that they may not be infective, the dwell time, as you can see in this bottom one over here, actually ranges from 3 up to 38.5 days, and complications from 0% up to 40.2%. So nearly half in some of the studies actually had the same complications, and the major one there is also infection. So merely because you place the central line peripherally is not going to make you have a non-complicated line. There are all sorts of reasons as to why patients actually do develop bloodstream infection. And in fact, 60% of all hospital-acquired bloodstream infections originate from some form of vascular access. And we see this all the time in the intensive care unit. Patients who otherwise are not or have not had surgery, do not have another obvious form of infection, that the central line is left with being the only source of infection as well. And they're catheter-related factors. It's related to the device that you're actually using. that the type and the use of the central venous catheter, the actual insertion site that you use, the frequency with which it's accessed, and of course in ICU, that's a major problem that people are always accessing them, even to pull blood from them, the duration of placement, and then the operator-related, where you've got the experience and the education of the individual who inserts the central line, the use of proven preventative strategies, if they actually are used, and very frequently they're not, and I'll talk about that in a moment. And then patient-related factors, where you've got factors such as age, where your sepsis increases with older, more friable skin, severity of the illness, nutrition, poor skin integrity, and immunocompromise all have a role to play in terms of whether you develop infection or whether you don't. And not only that, the important point is that when you do develop a central line associated bloodstream infection, there is a significant attributable mortality. And this was a systematic review and meta-analysis of 18 studies with 1,976 CLABSI cases. The odds ratio of in-hospital death associated with CLABSI was 2.75-fold and 1.51 in a group subgroup of 10 matched studies. That was the 1.51. Overall was 2.75. And where more than 30% of the CLABSI were attributable to coagulase negative staph, the odds ratio of death was 1.64 versus overall 4.71. So the coagulase negative staph is associated with less mortality than the other organisms that will infect the central line as well. So the majority of the infections will emanate from the insertion site. So they're going to be there, the actual insertion site where it goes through the skin, with the development of a cellulitis frequently, sutures which are inadequately placed, and often it's preferable not to be using sutures and use a fixation device that allows you to fix that to the skin without the sutures. And then also, of course, to the hub, and there's the hub that we're seeing over there because of the fact that they use so frequently as well for the administration of medications and fluids. Why on the catheter? Why is it so important? Well, it's obviously related to biofilm. And we know that biofilm will promote cellular resistance due to the high mutation rate that occurs in the biofilm, or the organisms within biofilm that are exposed to some lower levels of antibiotics as well. And it's up to 100 times that of planktonic cells. And the pathogens facilitate horizontal gene transfer and acquisition and spread of resistance determinants within that biofilm as well. And diagrammatically, you can see attachment, microcolony formation in terms of the biofilm over there. Then you get a mature biofilm, and then you get disassembly and dispersal, and that gets released into the bloodstream as well, and you get distal infection or bloodstream infection occurring because of the biofilm formation there as well. So how do we stop this? Well, first of all, we need to think about our bundle, and they aren't particularly complicated things. The very first one is going to be hand hygiene, maximal barrier precautions on insertion, and I still see people wiping the skin with a little bit of chlorhexidine and alcohol and zapping it in whilst you've got gloves on, but without wearing your gown, glove, masks, etc., and appropriately draping the site, and not just putting one little cloth next to the site where you're about to insert the line. Chlorhexidine and alcohol skin antisepsis, optimal selection of the catheter site, and then daily review of the necessity of the CVC, because in fact, merely because a patient is in ICU does not mean to say that they need a central line. And many patients, in fact, don't need a central line, and they would be better off without it. I like to show this slide frequently, because even though it's from 2004, things really haven't changed dramatically anyway. If you look at the odds ratio for hand hygiene adherence, and you take medicine as being an arbitrary one, and then you look at the other specialities thereafter, surgeons in the wards wash their hands 83% less often than medicine. And that's not saying that medicine is particularly good, it's just they're a little better than many of the other specialities. ICU is not much better, 50% less than medicine. Anesthetists in this study were the worst. and emergency medicine was not much better than the anaesthetist. And if you keep your own hand rub in your pocket, you're at least 2.35-fold more likely to wash your hands. And of course, human nature, the awareness of being observed, 3.55-fold increase in people washing their hands if somebody's hanging over their shoulder. But unfortunately, it's not always possible that people can be watching all the time. And when I was head of the ICU, every single day, I would catch people wandering into cubicles without washing their hands and going directly to and touching and dealing with patients in the unit as well. One of the big problems at the moment in terms of the IPC requirements when one's dealing with COVID patients is that everybody's using gowns and masks. And because of the fact that they're using gowns and masks, and gloves, they feel that they are actually sterile, or they're able to then touch the patients. But the big problem is, of course, that once they have examined a patient or performed a procedure with those gloves, they are no longer sterile. And as a consequence, they will transmit organisms within the ICU as well. We know that hand washing really requires a significant use of an alcohol-based hand rub. A is without washing, B is with soap, and C is with alcohol. But it does mean that it's got to get onto all the surfaces of your hand, and it needs to also then dry afterwards. If you do not allow the couple of seconds required for that to dry, you're not going to get an appropriate sterilization of your hands as well. Now, what I did introduce into the ICU, and I hope they're still utilizing it at the moment, was a CVC bundle for the ICU in particular. And you keep the standard CVC equipment in a cart. A checklist was then made, and then the nurses were to tick off all of the procedures that were being performed, and if they were not being performed properly, they would then stop the procedure and make people start again. And of course, they then get into trouble because you're wasting money, and it costs a lot when you throw away lines because of inadequate sterility. You need to assess for removal of the central venous line daily. You need to state the line day during rounds and on the chart so that you can see how long it's actually been there. Keep your alcohol-based dispensers prominently and measure bundle compliance. And we had the alcohol-based dispensers looking at you in the eye as you walk into the cubicle. But despite that, people often did not use them appropriately as well. Whether you should put them into the subclavian, the jugular, or the femoral, this was a study by Parenti in 2015, 3,500 catheters. The primary outcome was a composite of catheter-related bloodstream infection and thrombosis, so it was both together. The subclavian vein was on odds ratio of, was 1.5, I should say, 1.5 per 1,000 catheter days. The jugular vein 3.6, which was about double, and the femoral vein a little bit bigger again, 4.6 per 1,000 central venous catheter days. And those were significant differences when you compared the latter two with the subclavian. The femoral vein versus the subclavian vein, if you looked at those two alone, the odds ratio was increased 3.5-fold, hazard ratio. The jugular vein versus the subclavian vein, the hazard ratio was 2.1. The femoral vein was equivalent to the jugular vein at about 1.3, and that was not significant. But there were more pneumothoraces with the subclavian than there were with the jugular. But that should be less now as more and more units access sonars to allow rapid and direct placement into the subclavian vein or even the jugular vein as well. Obesity is important in terms of central lines. 4 randomized controlled trials investigate the risk for catheter-related infection related to your BMI. 2,282 patients and a BMI of more than 40 had an increased risk for major catheter-related infection with a hazard ratio of 1.88. And that was significant, as you can see, by the 95 confidence intervals. Catheter-related bloodstream infection had a hazard ratio of 2.19, and colonization a hazard ratio of 1.44. And this was against or compared to a BMI of 30 up to 39. It was also associated with increased dressing disruption, probably because of sweating under the actual dressing itself. And the lesson really from the study was to try, in terms of patients who are obese, to minimize exposure to IV catheters and emphasize dressing integrity. Of course, that's not always possible because putting peripheral lines in very obese patients may also be extremely difficult. What about skin preparation? This was an open label randomized controlled trial, 2x2 factorial design, looking at any lines, specifically CVC, dialysis, and arterial. And they looked at 2% chlorhexidine and 70% isopropyl alcohol, so chlorhexidine alcohol, or 5% povidone iodine and 69% ethanol, plus minus skin scrubbing beforehand, as you would do with the surgeons scrubbing your hands. The chlorhexidine group, there were overall 1,181 patients, some being scrubbed and some not. And similarly with the povidone iodine, a similar number as well. Looking at catheter-related infection with the chlorhexidine group, it was 0.28 per 1,000 catheter days versus povidone iodine, which was 1.77 per 1,000 catheter days, with a hazard ratio of 0.15. So it is recommended that one should use chlorhexidine from the skin preparation point of view. This was a more recent systematic review and network meta-analysis, 1,511 studies, of which 5, that's 2,815 catheters were included. The catheter-related bloodstream infection with 1% chlorhexidine alcohol was less than that with 0.5% chlorhexidine alcohol. So there is a benefit with the slightly more chlorhexidine as well. Relative risk was 0.4. It had high certainty of being accurate. And it was also greater than 10% povidone iodine aqueous solution without alcohol. And the relative risk there was 0.31. There was no difference between the 1% chlorhexidine alcohol and a 2% chlorhexidine aqueous. In other words, without there being alcohol as well. The relative risk was 0.35, and the evidence was with moderate certainty. And the hierarchy of infection was, first of all, or best, was 1% chlorhexidine alcohol, 0.5% chlorhexidine alcohol, 2% chlorhexidine aqueous, and 10% povidone iodine aqueous in that descending order in terms of effectiveness. So if we looked overall at a plot in terms of chlorhexidine impregnated dressings, now this is after you've prepared and you've put your line actually in as well, and you've now got a dressing which has got a small pledget impregnated with chlorhexidine that goes over the actual insertion site of the line itself. And as you can see, there was a significant positivity rate in terms of favoring that which had a chlorhexidine pledget that was inserted. One of the important things in terms of infection is the risk of dressing disruption. And as I mentioned already, that occurs more commonly in obese patients, but occurs in many of the types of dressings that are used. So we have frequently these non-bordered type dressings that are just clear dressings that are placed on top of the insertion site, and they will come off. And the number of times that they do come off increases or relates to the incidence of infection. So from the risk of catheter-related bloodstream infection, there's more than a 10 times risk of infection with 2 or more unscheduled dressing changes occurring there as well. And that's a problem because hospitals are often reluctant to actually purchase the more expensive bordered dressings, and of course those that contain the chlorhexidine pads or pledgets that are able to decrease the infection there as well. This was another one looking at the chlorhexidine impregnated dressings and also strongly adherent dressings. So the ideal would actually to have both of those factors with a bordered one and not just one or the other. But in this study, it looked at 1,879, large number of catheters and catheter days. The chlorhexidine dressings, those that had an impregnated pledget, the major catheter-related infection rate was 67% less, 0.7 versus 2.1 per 1,000 catheter days, with 0.3. The CLABSI rate was also 60% less. This was 0.5 versus 1.3 per 1,000 catheter days, and a hazard ratio of 0.4. And if you had a highly adhesive dressing, but it did not have a chlorhexidine impregnated pad, then they would decrease detachment significantly, 64% versus 71%, but there was increased skin and catheter colonization underneath the strongly adherent dressing if it did not have the chlorhexidine impregnation. So then what about the infusion standards in terms of what one should be doing? Assess your catheter skin junction. You must look every day for redness, pain, swelling, and drainage, visually and by palpation as well. That's why you've got to have an open dressing so you can see what's happening underneath it, or a see-through dressing. You must use chlorhexidine impregnated dressings over and above any of the other dressings that might occur as well. So you've got to assess the need for the catheter daily, perform hand hygiene before manipulation of the IV system. Dressing change recommendations and guidelines should be based on the dressing type. And as I said, you preferably would be using this type of dressing over here, which has got a border and then a clear center as well, and can firmly attach to the site as well. The IV tubing and administration set, the secondary set, and the add-on device change guidelines should be based on the medication or the product infused, with significantly shorter for things like propofol or for parenteral nutrition. And you must disinfect the IV access ports with appropriate disinfectant as well. In terms of changing your dressings as well, the recommendation on a number of the organizations is to change the transparent dressings with site care every 5 to 7 days or sooner if loose, damp, or soiled. And if you are using gauze dressing, which you preferably shouldn't be, you need to change every 2 days. And in fact, most of the guidelines actually recommend the same thing. The CDC on the right at the bottom, change your semi-permeable dressings with every 7 days, or immediately if wet soil or soiled or dislodged, and gauze dressings every 2 days as well. So what about duration? When we're looking at the infusion set changes, how often do you need to change the infusion set? And this looks at any types of central lines that were actually utilized. And then the catheter-related bloodstream infection was adjudicated by blinded ID physicians. They had 7-day infusion set changes and 4-day infusion set changes with a large number of patients in the modified intent to treat group. The 7-day ones had an incidence of 1.78% versus 1.46 in the 4-day group. And in terms of catheter-related bloodstream infection, the absolute risk difference was 0.32, and that crossed 1, minus 0.73 to 1.37. So they were really not significantly different. And when we looked at the peripheral lines, it was 0.28 in the 7-day group, and it was 0 in the 4-day group. And that, again, was not a significant difference. So you can leave your infusion set the same so long as it has not been contaminated and disconnected on a regular basis. When we look at the types that you might change earlier, you would replace the continuously used administration sets greater than or equal to 96, but less than and equal to 7 days. Intermittently used tubing is unresolved, but if you've been giving blood or parenteral nutrition, they need to be changed within 24 hours of the start. And that also applies to propofol if you're utilizing it because of the high fat content, which actually is associated with infection as well. The INS recommends much the same. You should replace detached sets every 24 hours. Aseptically attach a new or sterile or compatible cover over the male end, and I'll show that to you in a moment, especially during intermittent use, and that's both for peripheral and for central lines. And they also say that for parenteral nutrition, that should be less than or equal to 24 hours, and blood after its completion or 4 hourly as well. So very high potential for sepsis. What about the patient? If you bathe the patient daily with a chlorhexidine soap, this was 5,008 patients. They looked at 19 months and then an intervention of 9 months with chlorhexidine bathing. Their baseline CLABSI rate was 2.45 per 1,000 catheter days. And then after the intervention was 1 per 1,000 catheter days. And we introduced, in fact, in the ICU, washing with once daily at least, with chlorhexidine-based soap as well. So it was independently associated with a reduced risk of CLABSI, an adjusted odds ratio of 0.47, and there was no change in etiology, except interestingly for an increase in Serratia in the intervention period. Not sure whether that was related to it being more resistant to the chlorhexidine or not. So one of the other big problems, of course, is the hub. And we see these hubs frequently hanging in the breeze, and often not even with their caps as well. And of course, organisms get into the hub, and 33 to 45% of them are contaminated in normal use. And these are bacteria cultured from an unprotected IV port. And I frequently see lines that are hanging from a patient's neck or their subclavian without any port or cap on them at all. So in fact, what we also introduced, and they are extremely cheap, and they hang on little stickers on a drip set in the unit, are these little port protectors. And they have within them 70% isopropyl alcohol. They'll disinfect within 1 minute, and they protect from contamination for up to 7 days if they're not removed. And there's a more than 99% reduction in common CLABSI organisms that you might see there as well. So as you can see in the diagram, it disinfects in 1 minute and protects for up to 7 days. And I would much rather, in fact, that what has developed in the wards is peripheral catheters, which are just closed with a normal cap, if they are closed. They're closed with a normal cap, and then the patient wanders around until it's used the next day again. There should be one of these little caps, which cost only a few cents, that are placed on any of the open ports on both peripheral and on central lines as well. This was a study we actually did some time ago, 2009. What about the very expensive chlorhexidine sulfadiazine lines actually impregnated with those such that they would decrease sepsis as well? And we had standard catheters, and we had 56 of these CSS triple lumen catheters. The study actually involved 34,951 catheter hours, 1,456 catheter days, and 3.99 catheter years. And interestingly, we found no difference in catheter-related infection rates between the impregnated ones and the standard catheters as well. Excuse me. And we suggested after the study that the standard CVCs can be left in situ in critically ill patients for up to 12 days and probably 14 days with appropriate infection control measures. But if in fact a patient does develop a rising CRP or a PCT or a temperature, and you don't have another obvious source, we would still withdraw or remove that catheter and send the line for culture thereafter. When the infection did occur, the most common source was the skin, and the administration of parenteral nutrition and site of insertion, subclavian versus IJ in our study, were not risk factors, as opposed to that study that I showed you earlier, which indicated that IJ was worse than subclavian. Perhaps that's because of the fact that one's using sonar now, and the insertion is much easier with less complication. Looking at K-galase negative staph, it's always been an issue. If you do in fact get a coagulase negative staph, it's coming from your, usually, unless you've got an endocarditis, it's coming from your central line. And this looked at a comparison of antibiotic treatment. This would be the IDSA guidelines, which said that for greater than or equal to 5 days, they should be treated versus no treatment. And the inclusion criterion was simply removal of a central venous catheter with a quantitative catheter tip, culture growing coagulase negative staph, and the same coagulase negative staph in blood. And they actually, more frequently, unsurprisingly, treatment occurred in severe neutropenia or hematological cancer and immunosuppression. But in fact, overall, 76% received antibiotics for more than 5 days, and 17% received no therapy. 32 matched pairs showed no difference in the frequency of non-resolution. So there was 0% of non-resolvers in the no treatment group versus 15.6% in those that did receive treatment. Having said that, do recognize that in the treatment group, there were more patients with severe neutropenia, hematological cancer, and immunosuppression. So it's quite possible that that might have been a factor with regard to their not resolving as effectively as well. The study we performed a couple of years ago now as well, a stepwise introduction of the Best Care Always central line associated bloodstream infection prevention bundle. It was done in a network of private South African hospitals. As you can see at the bottom, a very large number of private hospitals were involved, and both ICU beds and high care beds, which increased over time as well. And we had a number of phases to the study as well. From April 2010 to March 2011, it was specifically driven by the IPC nurse. There was commitment from doctors and the management and training of the IPC nurses. And then bundle compliance and the CLABSI rate was captured monthly. Phase 2 actually now was the so-called breakthrough collaborative method, which was a system that involved in multiple learning sessions, bringing in the nursing leaders, the IPC nurses, and the unit managers, so that everybody actually had a stake in the study itself. And phase 3, going up to 2016, there was then sustained goal setting, benchmarks, and audits. And what was important there was comparison that took place between the hospitals as well, and a certain degree of competition started to develop there as well. And as you can see, this is the initial phase 1. There's the phase 2 that occurred over there. And then over here, there was the goal setting, year-on-year improvement, etc. There were certain abstracts that actually came out as well during this process from the nurses as well. There were quality awards. And over here, you can see the actual incidence of catheter-related infections, the CLABSI itself. And over here, you can see the increase in the compliance rate that occurred with the criteria that were involved there as well. So there were 119,000 central line days, and bundle compliance improved from 73.1% to 90.5%. And generally, you don't see a benefit until you can get compliance improvement up to the rates of about 90.5% as well. And then this was highly significant in terms of the improvement that we saw as well. The CLABSI rate declined from 3.55 per 1,000 central line days to 0.13, and that was also highly significant overall as well. And it can be done, and it doesn't have to be done on a multiple hospital network. It can be done in one unit alone, where people can make a difference in terms of improving this as well. So really what this looks at is, if you can get a team leader who will start off showing people how to look after the lines and have appropriate IPC as well, the others will follow along as well. And I wouldn't want them to follow on just as sheep. I would want them to follow on well from an educational point of view, and knowing that they actually are doing the right thing when they are caring for their lines and they are attending to other aspects of IPC in the ICU. So thank you.
Great, thank you so much. We always miss the applause button on Zoom, but it was a fantastic talk. I always wait with bated breath for the final video in your talks, because that's often the best way to end. So please, for those who want to ask questions, just type them in the Q&A box. I've got some that have come through on, people message me as well on WhatsApp. I guess one of the sort of unknowns, but I wanted your opinion on it in terms of what you've seen maybe, is the effect of the improved emphasis on IPC with COVID-19 on any of these things. Do you think that it's going to lead to fewer line infections and related sort of nosocomial infections?
Unfortunately not. It seems that in fact, IPC has taken a second place in the care of patients with regard to bacteria. So people, seems to me, are more concerned with protecting themselves, which is very good, and I've got no problem with that whatsoever, and perhaps less concerned with transmission of bacterial infection or colonization from one patient to another. The other issue is that people like you, the ID physicians, have often been diverted away from appropriate AMS programs, and they're in the front line of treating people with COVID-19. And certainly that's happened in our hospital. And not only that, from a diagnostic point of view, the labs have been diverted towards diagnostic testing with regard to COVID, and are doing less culturing and surveillance that they would have done before. So I think it's a major problem. And if you look at the huge numbers of Acinetobacters and resistant fungi and all the rest of it in the actual COVID wards at the moment, it's really bad. And of course, remember, most of them are also receiving immunosuppressive therapy, and that doesn't help either.
No, agreed. And then there's a question that's come through, which I guess a bit more of a comment, but it's about saying that the third component of stewardship is diagnostic stewardship. And this is from a microbiologist saying, submitting a line to the lab for MCS, quote, just because it's been pulled out, could and often does lead to unnecessary and inappropriate antimicrobial therapy. Still something we see more commonly than we should in the lab.
Well, I think so. Of course, though, if in the ICU it has been removed and sent to the lab appropriately, because there has been an increase in the biomarkers associated with inflammation and clinical features such as fever and all the rest of it, then that becomes an important diagnostic technique for us. And yes, whoever was the microbiologist is absolutely correct. It's absolutely critical that we have appropriate diagnostic techniques.
Yeah. And then I wanted to ask about this Best Care Always campaign that you referenced towards the end of your talk. Obviously, that was done in many hospitals, but including did it include Charlotte as well?
No,
it wasn't.
It was net care hospitals only.
And do you know, I mean,
but we employed the same techniques in our hospital at the same time, but we weren't part of the study.
When you introduced it in the state sector, in other words, what did you find were the biggest barriers? I mean, did you find it was relatively easy to get off the ground, or were there problems that you needed to sort of overcome that you maybe didn't foresee in the beginning?
So no, it isn't particularly easy to begin. You've got to actually involve everybody in the process. And most important, in fact, are the nurses, because our registrars and fellows change quite rapidly. So no sooner have you trained them than you've got a new batch. And the nurses then have to actually take that bundle very seriously, that there's a printed sheet that they have to tick everything that is being done appropriately with regard to putting that line in. And unless you keep a very close eye on it on a regular basis, and you check that people are actually filling in those sheets, then you don't get adequate care of the lines themselves. And one of the big problems is, of course, also is that our nurses generally are not pushy enough in terms of enforcing these types of things. So they are reluctant to censure the doctor and stop the process when this occurs, and you've got to empower them to actually do that. It's not easy initially.
Yeah. Just one of the things, as you said, that's sort of a key driver of that is that everyone needs to be sort of empowered almost on an equal level in that. I mean, we have enormous problems with our IPC sisters, even at Till and Joseph Hospital, where they would go in towards find problems, communicate those problems, and often been sort of more or less ignored, unless they come with a big stick or a matron or something as well. But it's the one branch of all of this medicine where we really do need to sort of be on the same level playing field rather than in sort of hierarchical form.
100%. And in fact, that is in the private hospitals was a huge problem in that study as well, that they would be shouted at by doctors if the IPC nurse intervened in a process and abused. And that's on the doctor's shoulders mainly, who are not prepared to listen to advice.
And then there's some questions about changing the CVC, the central catheter. Kim is asking about what's your feeling about when to change it? In other words, only when there's signs of infection or prophylactically after a predetermined time?
So our study that we performed some time ago showed that if you place the line in an appropriate manner, as I described as well, that you can leave it in situ for up to 14 days. And we did that and we found no difference between the standard line and between the chlorhexidine, sulfadiazine impregnated lines. But having said that, often we didn't leave them in for 14 days because if a patient did develop a pyrexia, and in particular, if we got a culture out of the central line, and we had no other obvious site of sepsis, then we would remove it earlier. But very frequently we didn't find infection at the time. So there's no rule, because some patients will become infected early, but you have to then watch every day for any features of possible sepsis and look at your biomarkers on a regular basis as well, and then make your decision based on that.
Yeah. And then a sort of somewhat related question is about how do you deal with a patient who has prompt resolution of the fever after catheter removal, but then the catheter tip comes back with something like an enterobacteriaceae? And then the question also asks, would your approach be different for different organisms, like a coag-negative staph or something like that?
Yeah, that's an interesting one, because in fact, we know we have never treated the coagulase negative staphs unless, for example, they had a metal or a plastic heart valve in or something, and they had bloodstream positive coagulase negative staph, then we would think twice, but we don't treat the coagulase negative staph. And of interest, way back before your time, when we didn't have colistin, and we had what was then pan-resistant Acinetobacters in our unit, that we actually published a paper on that and on eradication of the organism as well. So we had nothing to treat those patients with who got line-associated Acinetobacter in their blood. And we removed the lines, and I would say all of them got better, because Acinetobacter also is relatively less virulent, shall we say, or pathogenic than the CLABSI, for example, or an organism such as that. And it's frequently the case that when we, as was mentioned, even with more pathogenic organisms, when you remove them, by the time you get your culture back, which might be 3 or 4 days or thereabouts, your PCTs come down dramatically, your fevers come down dramatically, and then in most of those cases, we actually don't treat them. But very often the line gets removed because you've got features of sepsis, and then we will have started the treatment already. But in those patients where there's been resolution and we haven't started therapy, then we often don't continue it.
And in those cases, are you recommending to pull central and peripheral blood cultures? I see that was a comment from Dr. Kilaratni.
Yes, we are.
Yeah,
that's always the best way of doing it. And if you can, and you can look at the timing of positivity of your culture through the central versus the peripheral one, you can often get an idea as to whether it is arising from the central line or not. Having said that, do remember that your central line sepsis may not always be intraluminal. It may be extraluminal, and that doesn't always tell you the answer then if you do your culture through the central and the peripheral line.
Okay. And then last question was just whether any of this advice, which applies to sort of 99% of the patients, would it be different in patients with, say, profound cytopenias from chemotherapy or something like that? So would you be more aggressive in taking out catheters at certain time points or anything like that? Or is it really the same principles, just with more kind of aggressive watching?
It's all the same principles, but there we have an additional problem often, is that they often arrive with permanent tunnel ports of one type or another. And then everybody's extremely reluctant to remove that permanent port, which happens to be in there. Much like the orthopedic surgeons don't like to take their metalwork out of legs and things like that. But unfortunately, when you get a positive bloodstream infection and you've got a permanent port in situ, you've got to take it out because that will persistently cause ongoing seeding into the bloodstream as well. But otherwise, it's also exactly the same, but perhaps even more intensive.
Great. Well, thank you very, very, very much. It's a real privilege to hear from you. And thank you. Got lots of comments coming in saying what a great talk it was. So I'm passing them on in lieu of applause. But thank you very much for your time. Greatly appreciate it.
Thank you. Thanks very much.
Oh, sorry. We've got one question which snuck in with the wire, if you don't mind.
Yes.
About your opinion on lock therapy, so antibiotic locks.
I've never been a major fan of antibiotic locks, only because of the fact that your infection could be both intraluminal or extraluminal, and people have utilized them using alcohol or other solutions in the lock itself. If you've got a very, very precious port, you might try that. I'm talking about your tunnel port. You might try a lock therapy to see whether, in fact, you can eradicate it. But in general, the best thing to do is to actually remove the line. Yeah,
agreed. Great. Well, thank you again. Thank you very much for your time. Hugely appreciate it. Yeah, and greatly appreciate it.